Actually, the conduction across the AV node can become slicker with a normal node. And once your sympathetics start predominating over the vagal influences, you will find that the PR may actually shorten. Or you can give atropine. So these are two ways in which you can easily.
An asymptomatic patient come with a heart rate of pulse rate of 48.
Yeah.
ECG shows a complete heart block.
Yeah.
The patient is totally asymptomatic.
Yeah.
You want to improve it, or we can?
The important question here is there structural heart disease or not? Now you have a lot of patients with congenital complete heart block. Okay. Yeah, everything may be normal. This may be a person with a congenital complete heart block. Many of them do have some degree of reserve. If you put them on a treadmill, you will find that the heart rate may go up to 97 to 100, but not really much more than that. Most of these people are asymptomatic through the first couple of decades of life. But now lots of studies are showing that many of these patients, if you follow them up for 30, 40 years, they do progress to higher grade blocks. Some of them even have sudden death. It may even be related to the Brady-related ventricular arrhythmias. So there is a school of thought which says that these people should actually be paced as they get older. Apart from that, you can have people with complete heart block which may be acquired. Again, if it is acquired, you've got to decide, is this a hypervagotonic syndrome? Say, for example, someone who's having a neurocardiogenic syncope. You can even get a complete heart block. But one clue there would be that you have sinus slowing plus evidence of disease in AV conduction from the AV node downwards. So that is a very good clue to say that it is because of a hypervagotonic situation. They'll also give you a history of multiple faints dating back 10 years, 15 years often. And you find that they're absolutely normal and they're structurally no problem. So if actually they had structural heart disease, nobody is going to survive that long. So in some ways, if someone comes and tells me I've had multiple faints over the last 10 years, otherwise I'm absolutely fine, it's quite reassuring because it makes it quite likely that this young person, what he has is probably a hypervagotonic syndrome. Of course, you can do a tilt test to try and tease it out.
Thank you, sir. I request Dr. Yusuf Kurte, interventional cardiologist, Indian Hospital, to present a certificate of appreciation to Dr. Paul Burgess.
Good evening. On behalf of ISECON and Father Muller's Medical College, once again welcome all the delegates from all over the India. And the enthusiasm you have shown in the first 4 talk was really great. I never expected that. No, still the people are so much of interest in ECG. At the beginning of the session, I had the feeling that ECG is a dying art. Let us come back to the narrow complex QRS narrow complex tachycardias. What is narrow complex tachycardia? It is very simple. When the heart rate is more than 100, when the QRS is narrow, that means to say that if the QRS duration is less than 0.12, then it is called as a narrow complex tachycardias. So what are the causes of differential diagnosis for narrow complex tachycardias? One is, that is a reentrant SVT, that is supraventricular tachycardia incorporating the nodal tissues. You have 2 types of tachycardias, that is AV nodal tachycardia and orthodontic AV reentrant tachycardias. Other one is involving the atria and the sinus node, that is sinus tachycardia and atrial flutters and other forms of atrial tachycardias. So if somebody has got a tachycardia where RP interval is less, then you should think of this patient probably having a reentrant tachycardias. It is a picturized demonstration of the tachycardias. I already mentioned to you the tachycardia can be involving the SA node. If somebody has got a tachycardia involving the SA node, you have got only one type of common tachycardia, that is sinus tachycardia. There are other various forms of, now recent forms of tachycardias, I do not want to confuse you. So there is a one common form of tachycardia is involving the SA node is sinus tachycardia. Then you have a tachycardia involving the AV node. You have 2 types of tachycardias. one is AV and RT, that is AV nodal re-entry tachycardia, or AV RT, that is called as atrioventricular tachycardias. The third form of tachycardia involving the atrium, that is atrial tachycardias. If any tachycardia involves lower, it begins below the AV node, then the QRS becomes widened. So it all comes under the broad QRS tachycardias. So what are the evaluation you have to do at the beginning? So in the baseline ECG, you should see for what is the characteristic of tachycardia, whether it is regular or irregular, if it is a narrow or wide, what are the morphological clues, that is I am going to mention, tell you in the later stage. Then the history is very important. Now we should not read any ECG, anything, not only the ECG, any reports, it may be a CT report or it may be a simple potassium report, you should not read without the proper clinical histories. So you have to take a history of whether the previous MI or LV functions and other things are important. What are the mechanisms? There are various mechanisms for arrhythmias, how the arrhythmias originated, pathophysiology of arrhythmias. There are three major mechanisms. One is triggered activities, and the second one is increased automaticity, and the third one is re-entry. In all forms of arrhythmias, 90% are re-entry tachycardias. What are the things required for re-entry tachycardias? There are two things are important. One, you should have a slow pathway, other one is a fast pathway. In the slow pathway, what happens is the conduction is slower and the recovery phase is slower, whereas in the fast pathway, the conduction is faster. So unless you have two pathways with a different velocity, you cannot have a re-entrant tachycardias. So how do you diagnose supraventricular tachycardias? So in the supraventricular tachycardia, you should have a 12-lead proper ECG. It is a must. You should not record any ECG, read any ECG especially for diagnosis of arrhythmia without 12-lead ECG. Plus, if it is possible, you can have one long strip with the lead 2 and lead V1. What are the points to be noted in any ECGs, especially patient you are suspecting a narrow complex tachycardias? One is the onset, whether the onset is slow or it is an abrupt, and how is it terminated, if there is a sudden termination or it is gradually terminated. The morphology of P waves, QRS complex is very important. Then whether it is associated with the bundle branch block or whether he has got his AV nodal blocks. So what is the commonest, which is the commonest type of narrow complex tachycardia? Anybody can tell? Anybody other? Next. The commonest type of narrow complex tachycardia, which is the commonest type? Sinus tachycardia, that is the best answer, correct answer. So answer is sinus tachycardia is the commonest types of narrow complex tachycardias. It is not the ABNRT or AVRT. So we think that sinus tachycardia is the normal one. So that's the mindset. So it is the sinus tachycardia. You can see here, what are the clinical features, ECG features? The heart rate is more than 100, the rhythm is regular. If you can go back and see here, the heart rate is more than 100, the rhythm is regular, P-wave morphology is normal, and PR interval is within normal limit, the QRS is normal, STT is maybe normal, sometimes may be abnormal, because there is something called as a tachycardia induced secondary changes. So that is the commonest type of sinus tachycardia. Second type of tachycardia involving the junction is called as a junctional tachycardias. Whereas, so how to differentiate junctional and whereas ABNRT, I will deal in the later stages, where you can see here there is a P waves. I will show you the P waves here. So you can see here the P waves here very close to the QRS complex. Also here it is very close to the QRS complex. So the QRS complex is P waves are almost, it is inverted in lead 2 and lead 3. So how do you diagnose junctional tachycardias? So what is the normal rate of junctional or the AV node rate? What is the normal rate of AV node? 40 to 60. So if it is more than 60, it is not the tachycardia. Normally, that is what happens is most of the tachycardias, if we call generally, if its heart rate is more than 100, then we call it as a tachycardia. The exception is, whereas in the junction, if the heart rate is more than 60, usually it is around 60 to 100. So the heart rate and PO can be inverted, especially in the lead 2-3 AVF. Also it can be in the lead V1. The rhythm will be regular, QRS will be normal, ST segments are normal. So these are the clinical features, ECG features of junction tachycardias. So the important thing you should see if you want to diagnose AVRT or AVNRT. This is a very important slide, you should concentrate here. So the diagnosis of AVRT or AVNRT is depending on the PR interval or RP interval. So whether the RP interval is shorter than PR interval, you can see here the RP interval is short and the PR interval is long. This is called, it comes under the 1 classification. This is the other situation where the RP interval is more than the PR interval. So these are the 2 types of arrhythmias. So what are the situations you will have a long RP intervals? Which are the tachycardias we can have long PR intervals? The one is the RP intervals. One is the sinus tachycardia. Second situation is the atrial tachycardias. Atypical AVRTs, that is atrioventricular tachycardias, not the routine one. Junctional tachycardias. Even some of the atypical AVNRT also can have a long RP intervals. So let us concentrate on what are the conditions, ECG conditions, where the RP interval is shorter. It occurs in most of the AVNRTs. It is typical in AVNRT and most of the AVRTs. So let us concentrate only on the tachycardias which has got short RP intervals. So you are left with only 2 tachycardias, narrow complex tachycardias. One is AVNRT and AVRT. So we don't use the word what is so called SVT now, because either you have to diagnose AVNRT or AVRT. So 90% of these tachycardias are reentrant tachycardias. Out of that 60% are AVNRT and 30% are AVRT and 10% are atrial tachycardias. 2 to 5% of the tachycardias can be because of WPW syndromes. So it is a quick I have already mentioned, it is a quick look of 12 lead ECG is very important, whether it is a narrow or wide, whether it is slightly regular or irregular. So most often when the heart rate goes up more than 180, if the heart rate goes up more than 180, you make it very clear, it is very difficult to with the eye to say that it is regular or irregular. It is always better to use a caliper or a paper. Don't say that no, okay, I feel that this ECG is regular. It is never. Sometimes you can miss an atrial fibrillations because the heart rate is more, especially if it is more than 200, that is impossible. So whether it is associated with ischemic or excitation changes. So it is a typical AVNRT. You have 2 pathways I have already mentioned. One is a slow pathway, the antegrade conduction down is the slope fast pathways with the blocked conduction in the slope, fast pathways and blocked conduction in the slope pathways. And the conduction again, you can see the conduction again in the fast pathways. So this patient will have a very short RP intervals, and this patient also will have what is called as a pseudo R waves in lead V1 or pseudo S wave in inferior leads in 1/3 of the patients. But majority, if you see a normal ECG, if you take a normal ECG in AVNRT, the chance of seeing a P wave is only 1/3. So what do you do now? If somebody has got a heart rate of 250, you are not able to see a P waves, rhythm looks regular. So what is the alternative now? Now how to say this patient has got a P wave or not? No, I am asking in the ECG itself. We are not treating, we are just ECG. Pardon? I didn't get you. Now how to detect it? Pardon? Anybody in the audience? Exactly. So you are always right. There are two options. Option number one is, no, you take the ECG at the speed of 50 millimeters at double standardization. So you will be able to see the merged P waves. Second alternative is you do a carotid massage and slow down the heart rate and you look for a P waves. So these are the two alternatives you have. So this is a typical AVNRT. Most common tachycardia is SVT is the AVNRT. Now usually the heart rate is more than 200, and look for R waves, that is a pseudo R waves in lead V1, and it is mostly AV dependent. Can you identify anybody here? It is an SVT, AVNRT or AVRT. Don't think that since I am talking, this is a slide is about AVNRT, it may not be AVNRT. Anybody can see? So anybody can answer? Pardon? It is a flutterer. How many are believing that this ECG is AVNRT? I learnt ECG by mistakes. So more you commit mistake, more you learn. A wise man learn by mistakes. Okay, let us start. We will not waste time now. So this patient has got what happened is, it is a normal. The first, the way QRS complex you are seeing here is a normal. Here what happened is the second, what happened is the PR interval is prolonged. Then it started with, it is an atypical AVNRT. So this patient had a typical AVNRT. So this patient, you can see what I was telling you about AVN and the pseudo R waves. So you can see the fixed, there is a RP interval. The RP interval is very short, and the deflection, the R wave deflection, there is the pseudo R waves. So this is about the typical pseudo R waves. So then the other one is a AVRT. So what you see here is the second syndrome. It is a normal patients with the pre-excitations. The delta waves PR interval is very short. Here what you can see is a PR interval, RP interval, it is prolonged. So this patient has got the pseudo R is absent. If you can see here, the pseudo R wave is absent. So if the patient has got a absence of pseudo R waves, heart rate is more, and narrow QRS, think of AVRT as a first possibilities. It is very clear here, the RP interval is very prolonged. If you compare here, from here to here, the RP interval is very prolonged, and the PR interval is short. So this is a typical of AVRTs. So these are the P waves, it is merged with the STT segments. So then how to differentiate AVRT or AVNRT? If somebody has got a pseudo RS pattern in the lead V1, then 90% chances he has got an AVNRT. If it is not there, then you see for the RPM interval. If the RPM interval is more than 100 milliseconds, it is probably it is a atrioventricular tachycardia. If it is less than 100 milliseconds, then you think of it is probably an AVNRT. If the patient has associated with depression, ST depressions is more than 2 millimeters, think of AVRT, and otherwise probably it is an AVNRT. So the other common tachycardia which is narrow is the atrial tachycardias. So usually the heart rate is around 150 to 200, and the P wave morphology is usually different from sinus. So, I will show you that typical atrial tachycardias. So, in a typical atrial tachycardia here, the RP interval can be variable. You see here the RP interval here, RP interval here, it is RP interval. They are different, and the RP interval is most often it is more than PR intervals. Most of these atrial tachycardias are because of increased automaticity, probably because of drug induced or maybe infections or inflammations or post surgeries. Then finally the narrow cavus complex tachycardia can be because of atrial flutters. Usually in the atrial flutter the heart rate will be around 250 to 350, and you will have a negative sawtooth pattern in lead 2-3 AVF, positive in lead V1. So, this is the typical atrial flutter morphology. This is the 4:1 conduction. Here you can see it is 2:2 conductions. If the conduction normally it is either 2:1, 4:1 in the odd even numbers, it can sometimes it can also change. So, here there are the typical pictures of atrial flutter: 2:1 conduction, 2:1 and 3:2 and 1:1 conductions. It almost mimics the 1:1 mimics like an AVRT. So, just to brush say that what are the other types of tachycardias is the reentrant sinus nodal tachycardia and syndromes of inappropriate sinus tachycardias. I am not going to deal because it will add to more confusion than anything. So, this is the last slide of the discussions. A 32-year-old female treated in the emergency room for palpitation. The first ECG was tachycardia and the second one is after adenosine. What is your diagnosis? This is the first ECG. This is the second ECG. What is the diagnosis? Majority say AVNRT or AVRT. Pardon? Sorry, this is the last ECG. Yes, sir, the same thing. This is AVRT or AVNRT. How many for AVNRT?